Good morning. My study is a comparative study on the changes in photopic negative response and pattern electroretinogram waveforms in established glaucoma, glaucoma suspects, and normal subjects. As we all know, standard automated perimetry detects changes only after the 30 to 40% of retinal ganglion cell loss, and it is also influenced by patient inattention, fatigue, and lack of understanding. So, electroretinography is a minimally invasive, direct objective assessment of retinal function, and PRG and PHNR are electrophysiological markers of the retinal ganglion cell function. So, our aim was to compare PHNR and PRG regarding their sensitivity and specificity to detect early glaucoma and its ability to detect the severity of the disease. So, we got the ethical clearance, and then we included 42 established glaucoma cases with disc and field changes, and they were graded into mild, moderate, severe according to the HERDOPS classification, and 42 glaucoma suspect with suspicious disc or IOP more than 20, and 42 age-matched normal with normal disc and fields were included. Of that, 2 subjects from the suspect and 2 from established were excluded because of the errors in recording. Exclusion criteria include visual acuity less than 618, patients with poor fixation, and ocular conditions other than glaucoma like the retinal condition which can affect the recording, and patients with dense cataract. So PHNR is performed with Roland Grant's field, blue on white background in a dilated pupil, and PRG was done with an undilated pupil. It took around 15 minutes, and the electrodes were placed on the cornea and reference blue electrode at the lateral canthus and the ground electrode at the forehead. The PHNR is a slow negative potential that occurs after the positive B wave. Actually, there are 2 negative waves, and the second one, which is deeper, is taken as the PHNR. And the PRG was recorded both for 8-degree and 16-degree checker size, and the PRG ratio was calculated by amplitude to smaller check size by amplitude to larger check size. So the data was analyzed, and we found that the amplitude showed a significant difference in the established case when compared to normal and suspect, which are statistically significant. And also, the PRG did not show a statistical difference between the established case and the normal and suspect. And when we PHNR amplitude also showed a statistically significant decrease in the established group when compared to normal and subject. And then we went on to compare the waves according to the severity of the glaucoma. And we found more severe the disease, the decrease was more. The amplitude and the PHNR also showed a decreased amplitude in more severe disease, whereas the PRG ratio did not have any statistically significant difference. We went on to look at the correlation. There was a weak positive correlation between the PHNR amplitude in both the checker size 8 and 16, but there was no statistical correlation between the PHNR amplitude and the PRG ratio. And when we looked for the ROC curve, the PHNR amplitude was a good predictor of glaucoma, whereas PRG ratio was an unsatisfactory predictor of glaucoma. And we went on to look for the ROC curve for predicting glaucoma suspects. Again, here PHNR was a good predictor, but then again here the sensitivity was only 76.3% with specificity of 50.6 and AOC curve of 0.619. So similar study was done by Suresh Vishwanathan et al., who studied only on PHNR, and he also found that it was decreased in the glaucoma patients, and the decrease was more when the disease was more severe. And he concluded that there's a potential role PHNR in early detection and possibly in monitoring the progression of the glaucoma damage. And there was a study which suggested that PRG ratio also has significantly reduced, but we didn't find a correlation there. And there's various studies where the ROC curve was 0.9 and 0.86, but ours could match only the North et al. Study where the AOC curve was 0.78. So we concluded that overall the PRG N95 amplitude and the PHNR amplitude are useful tools to detect early glaucoma changes and to detect the severity of the glaucoma, and of the two, PHNR performed better. The limitation was the cost involved, the technical training involved, and PHNR required pupillary dilatation, where PRG requires a clear media, dense cataract we cannot do. And these are my acknowledgements. These are my references. Thank you.
What made you go for this?
Actually, I wanted to see the glaucoma suspect. We always are in a dilemma whether it is a glaucoma, the fields. Then the OCT came. Still, we were in dilemma. Could this bring out something new where we could confidently say this glaucoma suspect is a glaucoma? But again, this AUC curve for that factor was not very good. It just satisfactory. That was the main idea of doing this. They've actually compared the OCT and fields along with this. That we couldn't do. Yeah, yeah. So we needed ethical clearance for all that because we're using a. Hmm. The basic difficulty was to get them trained in that because they're more into all this using in the retinal disease. They didn't have idea of glaucoma. So we had to sit and have discussions, long discussions. That was the basic difficulty which I faced actually.
Particularly very different.
Hmm. But the interpretation part was a little bit.
Interpretation is,
Hmm.
I see a ERG pattern, I don't have clue as to what the hell is going on, to be fair. So it is difficult and you need very specialized people for that. More importantly, it's not very practical in
Yeah.
and you can't stick it, all right, you can put a corneal electrode on a new patient, whatever, probably doesn't have a clue.
No, there were electrodes which we could, non-invasive, which we could keep in the temporal part also.
Corneal
But,
electrode is cruel in someone,
yeah.
if you put them on
Yeah.
3 drops for 6
So
months.
we use that for uncooperative patient. We use the electrode, which is non-touching with that. What is a disposable? It was a bit more costlier.
Good presentation.
Thank you.